you wouldn't really think that there would be conflicting advice from NICE, but there is. And although when I started talking about this, there was much more conflict, and things changed last year in October, as I'll explain, it still has left us with still some conflicts. And there are not only sort of professional problems with that, but also medical legal problems, because you will be judged in court if it goes to court, and a couple of cases have now gone to court, and you'll be judged by how you've behaved in relation to best practice and guidelines. So I think it's very, very important that everyone's aware of the studies that the guidelines are based on and which guidelines people should follow. The difficulty of veins is they're massively misunderstood, and because of that, people aren't really interested in them. When I say people, I mean doctors. Because when you go through, if you talk to vascular surgeons, all vascular surgeons want to do is carotids, aneurysms, the big sexy stuff, bypasses. When you make absolutely, well, I wouldn't say no difference, but very little difference in the majority of cases. You do save 1 or 2 people for several years. But if you look at venous surgery, it's now been proven by the reactive study, by the NICE guidelines, by everything else, that for every single operation in the UK, if you look at cancer operations, hip operations, any sort of operation you can think of, the one that has most advantage in terms of quality of life years per pound spent is venous surgery. But despite that, the NHS has decided not to pursue venous surgery. It's actively really turning people away, as we know, and that has a major consequence on leg ulcers and leg ulcers in the future. So pre-1984, we were always taught that varicose veins occurred in superficial veins. They were the bulging veins you see on the surface. We know that's not true. We know that only half people with varicose veins see anything on the surface. The other half, you can't see any bulging veins on the surface. So you can never, ever tell your patients they don't have varicose veins unless they've had a duplex ultrasound. You can only say that you do have varicose veins because I can see them. You can never say the negative, because 50% of people with CVI or hidden varicose veins, there is nothing to see on the surface until they have complications. We were taught they were cosmetic only, which is incorrect, and I'll come on to that in a minute. And we were told they could be stripped, which we also know now is not correct. If you strip them out, they just grow back again. We were taught that venous leg ulcers were a completely different condition. We were taught it was due to deep vein problems, deep venous reflux, and as such, there was nothing you could do for it. It was the cause of the skin damage and the venous leg ulcers. There's no real treatment possible, and because of that, only compression would work. It was right back, however, in 1984, when the colour flow duplex ultrasounds started coming out, that we realised everything that we'd been taught was incorrect. This was one of the first papers to show it from the Bournemouth group, and they showed that 36% of people who had venous leg ulcers had it due to varicose veins and superficial vein reflux. And that was a major, major change, because up to that point, if you had a venous ulcer, there was nothing you could do about it. It was just bandages, compression, and we'd known that for hundreds of years. Suddenly, we found that actually you could cure venous leg ulcers in some of these patients because the underlying cause was superficial venous reflux. As the duplex got better and people got better at using it, they started finding out that actually it's even a higher percentage of people with venous leg ulcers. And this paper from 1993, way before, in fact 20 years before the NICE guidelines, this showed that 53% of people with venous leg ulcers had just superficial venous reflux as the cause of it. And of combined superficial and deep was 32%. So that's almost 80 to 90% of people you can either improve massively or improve by performing venous surgery as part of your treatment of the venous leg ulcer. The British taxpayer then decided to, not obviously individually, but via the powers that be, funded a very important study which everyone else in the world has gone mad on and we tend to ignore in the UK, and this is the ESHGAR study, which you must be aware of if you treat ulcers. And this was performed in 2007. It's the highest form of evidence you can get, a true randomized controlled study. And this study shows very clearly that if you only compress the leg ulcer, or you perform superficial venous surgery in addition to compression, the recurrence rates are massively different, and or to put it scientifically, statistically significant. And you can see there from the graph, the black line or the blue solid line at the top is the recurrence rate if you've had this venous surgery as well as compression. And the bottom line there, the dotted line, is with compression alone. Now you will notice that I'm not claiming that we can cure leg ulcers. There's still a recurrence, and there's still need for compression, there's still need for dressings, but you're fighting an uphill battle if you don't correct the underlying problem first. So then the NICE guidelines came out in July 2013, and many of you might have missed this because unfortunately it was published under the name of varicose veins, diagnosis and management. And of course the word venous leg ulcer doesn't appear in the title. However, what's important to notice, and all of you should be able to quote this parrot fashion CG168, because this is what you'll be held up against, and this is what your standards will be held against, is it's a clinical guideline by NICE. And this is now being mimicked, and the Americans in the American Venous Forum and the Europeans in their guidelines, everyone has got the same wording, almost identical. Everybody now agrees with this in the world of venous surgery. So the referral to a vascular service, because we don't have venous services unfortunately in the UK, but the referral to a vascular service is called, is number one, people, as you can see, with bleeding veins, which is obvious, we would send that as an emergency, and then there's a list of which varicose veins are going to go towards causing problems in the future, and that's symptomatic varicose vein skin changes. But also in that list is a venous leg ulcer, and the venous leg ulcer is defined as a break in the skin below the knee that has not healed in 2 weeks. So if it heals within 2 weeks, it's not an ulcer, it's a cut that's going to heal. But if a cut doesn't heal, it's usually because there's an underlying problem, which most commonly is venous disease. And that stops the healing process, and that's your ulceration. Interestingly, you have to look at the one under that as well. There's also a requirement for you to refer a patient even if that ulcer is healed. So even if it's C5, even if you get the patient and it's a healed venous ulcer, the guidelines state you must refer that person to a vascular service for a duplex ultrasound. When they get to the vascular service, it is then the responsibility of the vascular service to perform duplex ultrasonography. It is not enough to do a handheld Doppler, it is not enough to do a PPG, it's not enough just to see the patient. They must perform a duplex ultrasound of the deep and superficial veins. And if they know what they're doing, they'll also look at the perforator veins. But unfortunately in the UK, most vascular surgeons haven't got that far along the venous line yet. And the duplex must be used to confirm whether there's superficial vein reflux, deep vein reflux, obstruction, and therefore a planned treatment can be made if appropriate, and that's important, if appropriate. And this is in people either with primary varicose veins or recurrent. Just because someone said, I've had my veins treated before, doesn't mean to say they've had a good job. And in my clinic, every week, I have 3 or 4 people who've gone to these cheap vein clinics that are springing up everywhere. They hand in the invoice and say, but look, I've had my veins treated, why are they still there? And when you actually then scan them, there's nothing being done on the inside. Everything, the wrong power was used, the wrong techniques were used, or a tiny bit has disappeared, but not everything. So just saying I've had it treated doesn't mean to say they've corrected the underlying pathology. There's a lot of mismanagement at the moment on the surgical side of venous disease, but that's a subject of a book I'm writing at the moment. As far as interventional treatment is concerned, if we find that there is venous reflux in the superficial system, then it should be treated by endovenous thermal ablation, which is incorrectly called in the NICE guidelines endothermal ablation. Doesn't make sense because endothermal just means inside you and hot. So it could be inside your esophagus, it could be anywhere else inside you. So it's got to be endovenous thermal ablation. If that is not appropriate or cannot be used, then you can use ultrasound-guided foam sclerotherapy, which is very much second best in truncal veins. Although I know certainly in the Midlands there are certain professors who are using just foam sclerotherapy, and that's why there's a huge recurrence rate. Stripping should only be performed in patients who are inappropriate for the other 2 techniques, or they're not available. And I can tell you in 25 years of treating varicose veins, we've not found a single patient who cannot be treated without those other 2 techniques. There is no place for stripping anymore. And we know the long-term outcomes from stripping is regrowth of the vein and recurrence, so it should not be performed. However, it's still in the guidelines because some doctors still do it. This is a very important guideline, and remember once again this is a guideline. Do not offer compression hosiery to treat varicose veins, and by that it also means leg ulcers therefore, as a treatment unless interventional treatment is unsuitable. So you have to have proven that there's the treatment of the superficial veins is the patient is unsuitable or the veins are unsuitable before you turn around and call your compression a treatment. Now, of course, you put people in compression straight away, obviously, if they've got the ABPI, because it's part of the getting them to treatment, but you shouldn't then say that is the treatment. That is only what you use in the short term until they've been assessed and you have a proper management plan. After those guidelines came out, one of the criticisms of the Eshgar study was they turned around and said what they didn't look at was the lead time. Does doing the operation actually, you can start compression on a day, but you can't do the operation on the same day. You have to put people on a waiting list. So therefore, nobody take into account, does the operation actually increase the speed of healing? Is it just recurrence it changes, and where does that start? So you have to look at the whole patient journey. So this famous study, again paid for by the British taxpayer and used elsewhere in the world, but rarely in England, is the Evros study. That's a randomized controlled study again. And he put the two different people in. They looked at people who had immediate endovenous surgery, and immediate means within 2 weeks, which in the NHS is phenomenal if you've got a waiting list of only 2 weeks. Or delayed, should you, and I think they only managed that because it was a study, or delayed endovenous surgery. In other words, you waited until the ulcer had healed, or if it hadn't healed in 6 months, then did it. So you basically waited to optimize the patient. And in fact, there's a huge advantage to getting on and doing the procedure. You don't wait for the ulcer to heal. You just give antibiotics, clean the leg, treat the underlying veins, and it will get a faster healing of your leg ulcer. So if suitable venous surgery on suitable patients, if you're doing superficial venous surgery, you'll get faster healing and you'll get a lower risk of recurrence. So you'll save a huge amount of your time and NHS money if we follow the guidelines. What does this mean? Those of you who came to the workshops yesterday, I'm sorry because you'll just see the next two slides, you've seen these before, but the basic patterns we find in people who are treatable. Now, I'm not talking about all the other patients that you see who don't have treatable venous disease or have ulcers for other reasons. I'm only talking about venous leg ulcers now, but that is 80 to 90% of the workload. So you can have superficial vein reflux, you can have perforated vein reflux, which unfortunately in the UK only a few of us treat, but although it's easy if you're trained. You can have both superficial and perforated vein reflux, and those are predominantly the majority of our patients. Then you can have deep vein reflux along with a superficial vein and perforator, or you can just have deep reflux. Nobody so far has managed to make a valve that works. The only valves that work are the valves that you are born with. And when you grow a vein back again after stripping a vein out, the veins never have a valve in them. You only get valves, and the only time that the 5 genes and the 5 gene pairs cause valves, and the only time they're activated is in utero, when your embryo goes into being a fetus. So when you see veins regrowing, called neovascular tissue, they are always incompetent. So that's now why we ablate veins and we never take them out. So we should be able to cure at least the venous side in the first 3 cases. If there's combined deep and superficial, we can improve the patient, and then you can do things like stenting if there's an obstruction in those patients with post-thrombotic syndrome and obstruction. Now, this should mean that we should be able to cure about 80% of venous leg ulcers, and we know we can't because, as we've said in the workshops yesterday, for those who came, there are other factors as well. There's ankle movement, there's obesity, there's whether people have got good nutrition, there's many other things. But we still could reduce the workload by about 50%. And more importantly for you, and more importantly why I'm talking about this, is because medically, legally, that's also what we should be doing. There are other ways to treat veins as well. If you ever put an ultrasound on an ulcer, a venous leg ulcer, you will see great big veins underneath it. You can't see the varicose veins, but they sit under all ulcers, and also venous eczema, also under lipodermatosclerosis, under any skin damage, and that's called the subulcer plexus, or if there's no ulcer, it's called the dermal subdermal plexus. It's in dermatology books, and it's just started to appear in venous books, but I haven't seen it so far in any leg ulcer books for nurses. But what you find is these are the stasis veins. These are the ones that let the blood just sit there, circulate, metabolize, increase the carbon dioxide, decrease the pH, and cause acidic burns over your fasciocutaneous compartment. So in countries where they can't afford endovenous surgery, or they can't do it, and I think England's probably heading that way, you can actually do a temporizing technique where what you do is you just inject foam sclerotherapy into these veins and leave the great venous vein perforators. We know it's a temporary because it's going to reopen if you don't take away the perforators and you don't take away the reflux opening those veins up. But at least you'll get a great big boost, and you'll find that your compression, whatever you're doing, will improve dramatically if you do the TRIS method as well, if you have this foam sclerotherapy taking away the stasis veins. This was published by Ronald Bush and his wife, and they have actually now gone on to prove this. And this is used all around the world, but this is something that is a different way of doing sort of like a minimal amount of endovenous surgery that isn't going to cure, but is certainly going to assist for a few years. Just what I said earlier on about the progression, this is the most important thing. Varicose veins and hidden varicose veins are not a different condition. It's been well proven now by Rabe and Panier that there is a 4.3% chance every year that anyone with venous reflux or varicose veins will proceed to the next stage, which is swelling. 4.3% that they will go on next year to skin damage, and a 4.3% they'll go on to a leg ulcer. It is a progressive disease of fasciocutaneous damage due to reflux stasis or obstruction, but usually reflux and stasis. This is where the problems start now, because NICE also has got this thing called a clinical knowledge summary. And when you put venous leg ulcers into NICE, it's likely that this is going to be what crops up. And you're going to see the clinical knowledge summary. And this was updated because several of us had pointed out before that it doesn't correlate with the guidelines. So I've been looking at the new updated guidelines, which came out in October 24, and they still really don't help you very much. They're very good as a management from beginning to end, but they will lead you away from what you are legally obliged to do, which is follow the guidelines. It's very verbose, but I put it down into quite simple headings, and it says take a history, which I'm sure we'd all do. And one of those things, it says to look about the risk factors. There's a link, so I'll come back to that in a minute. Examine the patient, assess the ulcer, you'd expect that. Check for venous insufficiency. Now, that's very good, but it only says check for it. And there is a link then to the varicose vein part, but not the guidelines again. Then it tells you to look at them standing and lying, which is great for the 15% of people with visible veins, but the other 15% of adults who have varicose veins that aren't visible, the chronic venous incompetence, well, that won't help you at all. And then assess for arterial disease, etc., and ABPI and blood tests, as you all know. The trouble is the investigations they recommend are ABPI and blood tests, and they don't recommend that you refer for venous duplex. So they don't say don't do it, they just don't mention it. If you click on the links to see, do you get better advice when you gather the links? If you go to the risk factors, they actually state that you have the sustained venous hypertension, which those of you who went to my workshop know doesn't exist. There's no such thing as venous hypertension, except for in the ambulatory situation. The pressure of your ankle is how tall you are, and it's nothing to do with whether you've got varicose veins or leg ulcers or not. There is no difference in pressure. But what they're writing is it's due to venous insufficiency or impaired pumping. And they will tell you about other risk factors, but still, they don't actually then talk about what to do about it. They just say, this is a risk factor. Then click on the other link about varicose veins. They'll tell you varicose veins are bulging veins. Well, that's right 50% of the time and wrong 50% of the time. And amazingly, despite all this other evidence, they still say it's a cosmetic concern in the majority of people. They recommend referral only if it's bleeding. That's an immediate referral. And after that is provide information, and it only says consider referral to a vascular service for consideration of interventional radiology, and that's if it's not bleeding, but it's only, well, if you want to. And it's so far hidden down, you've got to have gone away from the CKS pathway, and you've got to have gone to a link and then read all the way through it. So it really is hidden away, and even then it doesn't say you have to do it. And then at the end it says compression stockings, which we know is wrong already from the guidelines as a treatment, but although it's part of the management. If you then go into the management section of this, assess for immediate referral, we've already discussed that, and then if not indicated, compression, ulcer cleaning, pentafoxylin should be considered, assess and manage complications. After the ulcer is healed, you should offer compression, and the reason for that is, of course, you haven't assessed whether there are varicose veins and therefore you haven't treated them, and so that's really out of date as per about 1984. For non-urgent referrals, you should refer to a specialist specialist if, and it says some ridiculous things, a diagnostic uncertainty, I'm not sure really what that means. If the ulcer is rapidly deteriorating, I think that's absolutely right, then all these other horrible things, ulcers, malignancy, etc., we should all accept. And then this is really, there's poor ankle mobility, which I'm not sure, I mean, you might go to physio, but you'd have to make a judgment call on that. But I think it's quite interesting to say if you've got a suspected iliac vein stenosis, I don't know how many of you have ever seen an ulcer patient gone, gosh, I think that person's got a suspected iliac vein stenosis. I mean, what a ridiculous thing. If you're not having a duplex or something, how clinically are you going to suspect it? I mean, in the whole of my life, I think I might have seen 1 or 2 patients which I might have thought, I just wonder. But these are sort of the things when you have people sitting in a room who probably aren't seeing a lot of ulcers themselves, but coming up with what are good ideas, and then they come out as sort of summaries. Worsening this, unfortunately, this thing, Betty's story, is still going round. It's not guideline, but it's still going round. It was from the NHS. It is all for the right reasons, but if you look at Betty's story, it's completely and utterly management, straight away by compression, managed by all these things. Nowhere does it say, and try and find out if there's a reversible cause. And it's just abysmal. So what should you follow? Because you could turn around and say, but I'm following CKS. Or you could say, I'm following NICE guidelines, so you could try and meet that. So in any case, these are what they actually say on the website about the difference between the two. But as we all do nowadays, I went to AI and I asked Google and I said, if there's a discrepancy between the two, which should I follow, the guidelines or CKS? And it says you should follow the NICE clinical guidelines, and the reasons why, and this is what the barristers will tell you, it represents the most authoritative and formally approved guidance from NICE. The CKS is just a practical summary of best advice and there's less formal oversight. In other words, people have been tasked to read it, it sort of looks good, and they put it up. And until somebody objects, that's the one that will change. Whereas the CG168 has got to have reams and reams of proven randomized controlled studies, and that's the authoritative one. So you have to follow the NICE guidelines. If you do not follow NICE guidelines, you are breaking NICE quality standard 67. And that means if you haven't referred the patient for a duplex, then, and there's any superficial or deep vein problems and you don't know about it and you're treating the patient, you're breaking NICE quality standards as well as the guidelines. And breaking it can lead to legal action. This is the book I wrote on it, Leg Ulcer Treatment Revolution. I bought loads last year and was giving them out, and if Ali asks me next year, I'll bring some and give them away as well. I forgot this year. The lady at the top, she had had her leg ulcer for 4 years. It destroyed her job, destroyed everything, because she just had to keep on going for dressings. And when she paid for herself to come to my clinic, she just had great venous vein reflux, and she had some perforators. That's the pictures there. She had endovenous laser ablation, then she had foam sclerotherapy, and 18 weeks later, she didn't even need compression. She was one of the lucky ones with good ankle movement, a pretty healthy lady and completely cured. And to date, has not had any recurrence, but has been to court and has actually managed to sue the nurses who are looking after her, because there were 70 contacts between her nursing care team and her, and none of those 70 contacts between, and this is since the NICE guidelines were out, in none of them did anyone say, oh, by the way, you could have a duplex, or even try to refer for a duplex. And the GPs were also pulled into the suing and were found to be culpable, because there have been 4 times GPs had gone in and they said, oh yes, it's a leg ulcer, you're fine with this. And nobody, even the GPs, nobody had said, by the way, you should have a duplex to see if you've got superficial vein reflux. The man underneath is even worse case. He had leg varicose veins. In fact, he's called Snake Boy at school at 14, so he knew he had varicose veins. At 19, he had brown stains around his leg. He became a manager in a restaurant, and then he was so young that people wouldn't believe it was venous disease, despite the fact he was called Snake Boy and he had massive varicose veins. So some dermatologists said it must be pyoderma, gave him steroids, has given him 5 crush fractures of his spine, all sorts of complications, overweight and everything. And it was 34 when he eventually came to us. And again, he's just got great venous vein reflux with perforators, totally cured, and now he's putting his life back together and is negotiating what payout he's going to get for having had his young life destroyed by not having the right treatment. And there's about 300,000 people, if they knew these stories, who could probably start cases. This is obviously the problem. The problem is it's reducing. There's a bit of a blip with COVID, but basically the NHS, as you know, doesn't want to do venous surgery, and the waiting list is getting longer. And I do understand there's a resource problem. So the conclusion is, morally and legally, you must follow NICE guidelines CG168. And if you don't, you must have a really good reason that you'd be prepared to stand up in front of a judge and say, this is why I didn't follow it, and it's written in the notes. but I'm aware of it. Because, and remember, that's anyone with a break in the skin over 2 weeks more below the knee or has had a healed ulcer. Now, resources might not allow you to do that, and I know all the time people are, the first question I get asked is, oh, but we can't refer because there's not enough money, there's not enough this, we're not allowed. But that will come back to you if you've made that decision. If you've tried to refer and said, actually, by CG168, this patient should have it, I understand if you can't afford it, but that's the best thing. You're covered. You've done the right for the patient as a patient advocate. You've done the right for you medically. I don't think you should die on a hill. I don't think you should lose your job. I don't think you should fight for it, because this is real life. But you should point out that the guidelines exist, and they exist for good reasons, and you should continue, but you should make it heard. Each time you have a patient, you should say, this is what the guidelines are showing, until it changes. So as I say, if you are going to be a patient advocate, you must know the CG168, and those are the guidelines you should follow. Thank you for your attention.